our guest speaker, Professor Alan Silman. Now, Alan was a professor at Manchester University Medical School, where he was a consultant in arthritis and rheumatology. He then went on to become the medical director of the Arthritis Research Council, which is now known as Versus. He has lectured extensively worldwide, and he is now the Senior Research Fellow at Green Templeton College at the University of Oxford, where he is the college's lead on global health policy. He's become one of the UK's leading, he is one of the UK's leading epidemiologists, but more importantly, in 2 weeks' time, well, less than 2 weeks, he is going to be elected, if he wins the election, the president of B'nai B'rith Cheshire in South Manchester. Now, Professor Silman, if you would like to unmute yourself, we're going to do something a little bit different this evening, as you suggested. Rather than give a straight lecture, we'll have a conversation. And then if people want to chip in with questions, I must ask you, please, could you do it through the chat button by pressing on chat and sending us a message. And my lovely assistant on my right, who you can't see because she's behind the screen, will give me the questions and we'll go through them. So Alan, welcome. If you'd like to unmute yourself, please.
Hello, and thank you, Alan. And just very briefly, a welcome to all my friends, particularly those who came on the trip to Ukraine a couple of years ago. It's great to see those familiar faces.
Okay. Should I kick off then, Alan, and ask you, why did this virus, because there have been plenty of other viruses, SARS, probably one of the most recent, why did this virus take over the world in such a fashion? What is different?
Yeah, I think that's a great question. And I think a number of things here. I think the first thing is this is a virus that crossed species. Normally, viruses are specific to one species, you know, a dog distemper virus and et cetera, et cetera. But here is a virus that crossed over species from bat to man. And because it crossed over species, it was infecting a species, man, who had had no exposure to it before. So predominantly, most of the population, the human population, had no immunity, which is quite unusual. The second thing about this virus, which makes it such a very clever enemy, if you will, is it has the ability to evade our front rank defenses against viruses. Normally our, the passages inside our nose, our throats, the upper airways have natural defenses. I'm not talking about antibodies, I'm talking about frontline defenses. But this virus has the ability to evade those, establish itself and grow and multiply. And having grown and multiplied, it can then do its harm. So in brief, two things: it was crossing over species and affecting humans for the first time. And it was very cleverly avoiding our first line of defense.
Okay, thank you. So going on from that, can we expect further pandemics like COVID? Is this going to be part of our lives? And do you think we will require further modified vaccinations on a regular basis?
Gosh, well, and there's a number of points there, Alan. I mean, I think the likelihood of viruses crossing species is always been there. And there are occasions in the past when this has happened. I mean, you referred to previous coronavirus pandemics, SARS and MERS. And what was interesting in those pandemics is, for reasons that we don't fully understand, when we were worried that they were going to get established, they just kind of disappeared. So there's something rather unusual about this coronavirus. In the bat caves, it sounds like a comic, isn't it? In the bat caves in China, there are a large number of other coronaviruses, which in theory could cross species and become established again. I mean, in terms of your second question about modified vaccines, I think that we need to distinguish between whether we are going to need vaccines, and maybe that might come up later, for new variants of this virus, or whether we're going to need vaccines against completely new viruses, coronaviruses, and others. I think maybe the message of hope I can give, fellow members tonight is there has been a dramatic shift in our scientific capacity worldwide over the past 12 months to an extent that none of us could have ever foreseen. And I think the consequence of that is that whatever else is thrown at us, whether it's a new virus or a new variant of the current virus, we will be much better prepared.
Okay, thank you. Talking about the vaccinations, most people on this Zoom will have had their first dose, and perhaps within 2 months, they'll all have had the second dose. What confidence do you think that people should have that after receiving their second dose, they won't have to worry about COVID anymore?
So this is the number one question, and I think we have to recognise that we are dealing in a changing situation. The situation is changing for a number of reasons. The first thing that's changing is that clearly we're dealing with a new vaccine, and we don't know how long the protection lasts. The clinical trials that were rushed through in order for the vaccines to become available for consideration to be licensed towards the end of last year had approximately 1 to 2 months of follow-up. In the real world, as vaccines have only really been rolled out since December, January, there's a relatively short period of time that we have follow-up. So if you say, do we know for sure what's going to happen, even if there's no new variant, even if there's nothing else changes, do we know that protection will last 6 months, a year, 2 years? Well, the short answer is we don't, because we haven't had that length of follow-up. What we do know is, and people will be aware, that many vaccines are very efficient and could provide lifelong protection. Smallpox, for example. So in general, our experience of vaccines where the virus doesn't change is this vaccine should provide protection. So that's point one. The second point is, and I can't believe that any of you haven't been following the news, is what does protection mean? If you imagine there is a spectrum, and at one end, you contract the virus, you have it growing inside your nose or your throat, you're perfectly well, but the only thing you can do is you can cough it, sneeze it, shout it, laugh it out, and it can infect other people. Not a problem for you, a problem for the people around you, and a problem for public health. The next stage is people have a mild infection, a common cold, something like that, a cough, moving on to something severe, moving on to very, very severe disease, ending up in intensive care unit or dying. Now, what we do know thus far from the vaccines for the current strains, they are remarkably effective against people getting seriously ill. So given the caution I said about length of protection, I feel all the evidence suggests at the moment that these vaccines will protect us as individuals from having a significant health problem resulting from COVID. Now, that still leaves the question, will it stop transmission? Well, the answer is we don't know. And interestingly, and maybe people really haven't thought about this, we don't know much about the transmission of viruses. We don't know about how many people have asymptomatic flu virus or cold virus or other viruses, because we've never had, until this pandemic, the mass testing. If you wind back a year, we did not have the capacity within this country to do mass testing, PCR testing, lateral flow testing, or anything. So we didn't know. We had no idea how many people had asymptomatic infection. But at the moment, therefore, it is possible that you've had the vaccine, you could still pass the virus on to other people. Now, if everybody else has had the vaccine, or vulnerable people have had the vaccine, if you pass the virus on and they're all carrying it, it might not make a difference. So that's the second point. The third point to your question is, do we need to worry about new variants? Well, this is a challenge because, again, the answer is we don't know. There are a large number of new variants. You will have heard about Brazil and Kent and South Africa and California. There might even be a Radlet variant, for all I know.
Everything's sterile here, it's okay.
Okay, that's good. I think the issue, which does appear to be the case at the moment, is the vaccines provide, if you like, a surplus of immune protection compared, for example, to the immune protection you might get after a natural infection. Now, that's not always the case. There are some infections where you get better protection after natural infection than you do with a vaccine. As far as the vaccines are concerned for COVID, what we know at the moment, the opposite is the case. Why is that important? Well, it's important for this reason, because there are people who are developing a second infection. And interestingly, some of you will have read about Manaus in Brazil, which had very, very high rates of COVID infection in the first wave. And with the new wave in Brazil, people who were infected first time are now being infected second time. Their protection from their natural infection doesn't seem to have protected them from getting ill a second time. Contrast that with the vaccines, where in the laboratory, and that's all the evidence we have at the moment, there is, if you like, a surplus level of protection from the vaccines. So they are very, very effective against the existing variants. Most people's opinion at the moment is that there is still enough reserve in them to be protected against the new variants. So, summing up a rather long answer, and apologies for that, do we need to worry? I think we need to be aware, but I think the level of worry, the level of anxiety that we've all lived under the past 12 to 15 months can be very reasonably decline.
Okay.
Thank you.
Could I ask you, Alan, what's your view about the wisdom of waiting 3 months between doses? I know most of the people I know who are Jewish would actually have been very happy to have 2 doses of Pfizer, followed by 2 doses of AstraZeneca, followed by 2 doses of Moderna, and 1 dose all in the last week, if it was possible to have it. What's your view on having to wait 3 months instead of having it done within 3 weeks?
Yeah, coupled with a smoked salmon bagel, presumably.
Yeah.
I think the interesting thing that everybody realizes, I'm sure, that all vaccines, or not all vaccines, a large number of vaccines are given as multiple doses. And you'll be aware from your own life, your children, your grandchildren, etc., that there's an infant immunization scheme when you have immunizations against a number of diseases, infections when you go on holiday, cholera, etc., you often need more than 1 dose of a vaccine. And everybody knows that you don't have the 2 doses 2 days apart. Why is that? Because we know that actually vaccines work best when there is a booster after a time that the body has had the chance to develop the machinery which allows it to develop a memory, which then when you're faced with the virus will go into action. And if you think of it, there's a lot of stuff going on in your immune system behind the surface, and it doesn't all come into play the first day, and it needs a period of time. Now, the way that the vaccines, most of the vaccines that are now available for use against COVID, they were all designed based on laboratory testing in the early phases that came out in the summer last year, that around about a month was the perfect time for the second the injection, the booster, if you will. And because of that, when they started doing the clinical trials, this is what because the clinical trials done by the vaccine manufacturers, the design of them is determined in large part by the regulators, the government bodies that are going to license the vaccines. A vaccine company can't just go ahead and do a vaccine trial without consideration of what government regulators are going to do. So they will have agreed with the European Medicines Agency, with the Food and Drug Agency in the US, with MHRA in the UK, etc., etc. They say, okay, we've seen your laboratory data, we will test this vaccine 2 doses apart, and we won't even look at what happens between doses because the vaccine comprises 2 doses. Now, 2 things happened. The first thing is that AstraZeneca did their study in the UK, Brazil, and South Africa. And for a variety of reasons, although they planned to have the second dose of vaccine within 4 weeks, in practice, because of logistic issues, etc., a number of people ended up waiting up to 3 months. And when they analyzed the data, they actually found that the longer the wait, the better the protection after the second dose. And that was one of the prime reasons why the government said, well, the AstraZeneca vaccine should be delayed 3 months, because the 3-month delay, providing people don't take advantage and consider themselves vaccinated, 3-month delay was better than the month delay. And given everything else that's going on, what's another month or 2 months? When it came to the Pfizer vaccine was 95% effective after 2 doses, 3 weeks apart. So it seems somewhat perverse not to allow people to have the second dose at the appropriate time. And indeed, I felt there was a very strong moral argument for individuals whose key jobs required them to face the possibility they could contract the infection, health workers, care home workers, that society had an obligation to protect them as quickly as possible. So there was a very powerful case, irrespective of anything else, that 3 weeks for them would have been appropriate. The UK government at the time, and I was neutral when they made the decision, was saying, but look, we do not know what the supply of the vaccine is going to be. We don't know how easy it is to roll out the vaccine. And when the license body, MHRA, met with Pfizer to look at their data, and this wasn't released, actually. I only saw this data about a month ago, but the regulator saw the private data from the company. They actually showed that although Pfizer, in their clinical trial, only looked after the second dose at 3 weeks, because of the way they conducted their clinical trials, some people actually had a 4-week gap. When the regulator looked at people who'd had their second dose from 14 days to 28 days after their first dose. In that gap, there was very, very good protection. And so the regulator said, yeah, I can see that we are going to need 2 doses for complete protection, but actually 1 dose, even after lying for 2 weeks, after 2 weeks, people get very good protection. And we have to remember something else, that we've been in lockdown since going back to these, what are they called, the different stages, phases, phases, 1, 2, and 3, lockdown group. Tiers. The number of cases was increasing. The number of cases was increasing. In January, towards the end of January, the NHS was in danger of being overrun. In my own hospital, the John Radcliffe Infirmary in Oxford, that was in danger of going to meltdown. Every single nurse in the whole city that was moved from non-urgent work to work in that hospital. Colleagues of mine said it was, they were expecting 1,000 patients in the John Radcliffe Infirmary with COVID, despite lockdown. So the government said, we have to do something. And given what we know, that you can get very good protection against severe disease 2 weeks after the first dose, that's what we should go for. It was a gamble. I think in retrospect, it was the right decision.
Okay, just going on from that, there's a question, the questions are piling in, and I will come to them later, but one has come up that's related to actually having the vaccination from Lynn Lucas, who says that if one had a very violent reaction to the first jab, what kind of reaction should one expect from the second jab? Does a violent reaction indicate high protection in any way?
Well, I think it's interesting. I mentioned at the beginning that this vaccine has some surplus capacity in the immune protection that you're giving. And if you think about it, when you have the vaccine, you're having a large amount of foreign stuff injected directly into the muscle. It is a big quantity in bodily terms. And the body responds to that, not immediately, not through antibodies, but through a whole range of other responses, various chemicals, things that might give you temperature, muscle aches, etc., etc. It's part of the body's response to having a foreign protein injected in large amount, and it's good. So it's not surprising that you're getting a powerful side effect in some people. So, I mean, in a way, I want to kind of reassure both people, to reassure people like Lynn, yes, it shows that the vaccine has been recognized and working, but to reassure people like myself, who actually had no reaction whatsoever, that that what we know, that even if people don't get a reaction, the vaccine works. We know that from laboratory testing. It's quite interesting because the early data that came out did suggest that the reactions after a second dose were less than after the first dose. Other data coming out now suggesting that might not be the case. And I guess this will vary between individuals.
Talking about reactions to the vaccine brings me really on to anti-vax conspiracy theories. What do you think the government should do about anti-vaxxers? And what about the ignoring of COVID by the Haredi community, despite their terrible death rate?
Well, can I take that in 2 parts? I think anti-vaxxers are actually not a single group. And I think we need to be careful about lumping together the reasons why quite a large number of people don't want the vaccine. And it varies by country. Actually, in Britain, the proportion of people who are not having the vaccine is substantially lower for example, than what we know from PR campaign, PR exercises in France, in Germany, and the United States. There are a number of reasons. I mean, firstly, there is the issue, and it's interesting when I've been doing these sessions to younger audiences. I mean, I looked at the screen, and the demographic of people who come on a BB UK Zoom are people who know that the age group we're more vulnerable. Speak to people in their teens, 20s and 30s, and they say, we're not vulnerable. It's not going to be an issue for us. Do we really want to have the side effects? And if older people are going to be protected, why do we need it? So there's they're not opposed to vaccine as for people who need it. They don't see the value for themselves. So that's one group. There are people who are concerned about potential effects of vaccines, for example, if they are on drugs that are suppressing their immune system, etc., etc. People who want to become pregnant, people who are pregnant, people who are breastfeeding, and they're asking questions. So if somebody comes to me and says, I'm pregnant, I want to become pregnant, what does the data say? I have to be honest, and I say there is no data. The data that actually the viral infection is harmful, but if you say, do I know for sure that the vaccine is harmless? I can't, because we don't know the data. So there are a group of people for whom lack of certainty about potential side effects is a concern. On top of that, there are these issues of conspiracy theories, it makes you infertile, etc., etc. These are really very, very difficult to argue against. Many people will know the study done by Andrew Wakefield a number of years ago showing MMR linked to autism. That caused vaccination rates to plummet. It caused measles to become a serious problem. It resulted in a vast amount of research dollars being spent across the world to prove a flawed study was indeed flawed. And yet there are still people who believe that, and measles vaccination rates are still low. Of course, it's interesting, who did Donald Trump appoint as his vaccine supremo when he was in power? But Andrew Wakefield, even though he'd been banned from Britain. I mean, should anti-vaxxers be banned? I mean, it's not appropriate for me as an epidemiologist to have a view that's a legal view or what have you. What I can say is that there may be scope, for example, to do what's happened in some parts of the world. That, for example, in New York, you can't enroll your child into public school. That's their state-funded school, unless they've been immunized against measles. So one way of, if you like, addressing the anti-vaxxers is to say, fine, but actually there are some things that will be inappropriate for you to participate in. I mean, issues about Facebook and social media, etc., etc. And I do think that, we don't need to have balance, when I don't think the BBC, etc., need to give airspace to people whose views are harmful.
So does that mean you are in favour of a COVID passport?
Yeah. Oh, sorry. Yeah. And and Ruth just told me I haven't answered the Haredi thing, which I will do.
I thought you were ducking out on that.
No, I'll come back to it. The COVID passport. I think it's interesting. The challenge that people say is from a perspective of who polices that and who's responsible. But I know, as you know, Alan, in my job, I've been fortunate to travel around the world to some rather strange places. And there have been places I've not been allowed in, for example, unless I had a yellow fever vaccination certificate in my passport. So there is definitely a precedent for that in terms of travel. If you say, well, you can't go into Marks and Spencer's, or you can't go to the British Museum or National Theatre unless you can prove you've been vaccinated, that's putting the responsibility on the people who are responsible for entry at those places, and what's the legal sanction if people go in, etc., etc. So I think there are logistic challenges in doing that. Sorry, yeah, coming back to the Haredi community. I went to a very interesting talk a couple of weeks ago by a Jewish epidemiologist who works at the London School of Hygiene, who had done the research on the frequency of infection in the Haredi community in Stamford Hill in Hackney. And that was the research that showed there was a 60% infection rate based on antibody levels within that population. Now, there are a number of interesting things about what he said in that study. The first thing is that the Haredi community actually came to the London School of Hygiene and say, we have a problem, can you help us investigate? And as I think Michael Marks, I think was the guy's name who did the study, he said, there are other communities, there's communities in the Pakistani community, there are other communities which have very high rates and they hadn't sought help. So the Haredi community were aware of major problems and had sought the researchers' help in sorting those out. The second thing that emerged from that study was the major problem was the household size. I mean, despite, I know, the high profile events of, you know, weddings and Purim and whatever, funerals, etc., etc. In terms of most of the proportion, the high number of cases in that Haredi community were explained by the very, very large family sizes, household sizes, multi-generations, large numbers of children. And in a situation where these children could not be easily separated in terms of schools, etc., etc. So, you know, there is, I think I would hesitate to, if you like, characterize the Haredi community in general as being people who are willfully ignoring the issue. I think there is something about the way that that community lives, their family size, etc., that is putting them at high risk. And the second thing I have to say is, about a month ago, I was asked by something called Salford Healthy Communities, which is the organisation that organises primary care in Salford. For those of you not familiar, in Manchester, it's Salford, where there is the other large collection of Haredi people. And again, they were seeing what they could do to encourage healthier adherence to behaviour. And again, for most of the Haredi community, there is a willingness to listen. There's a challenge because of lack of education, lack of access to modern media, etc., etc. And I'm sure there are some people in the Haredi community that are anti-vaccination and ignore the rules. I think a large number are sticking to the rules as they see them. And to me, and I'm you know, as you know, Alan, I'm on the progressive wing of Judaism, but I actually feel that we shouldn't victimize. I think there's a group that need our help and support, and I think the majority, as I understand it, are reaching out for that.
Just again about the Haredi, I have been asked a question here by even Tony Swain. Do you think they'll develop herd immunity?
No, that's not bad. That's not for me.
Well,
oh, sorry, it's from Karen.
Okay.
Yeah.
So, I mean, the herd immunity issue is an interesting one, and actually, it's probably turned out to be a false premise. Sir Patrick Vallance, who appears on the other side of Boris Johnson in the Downing Street press briefings, said in March last year, well, what we want to do is achieve herd immunity. And actually, herd immunity is very difficult to achieve, and it's difficult to achieve because it appears that the infection and vaccines do not protect against being able to transmit further infection. And we've seen in Manaus in Brazil, which has the highest rate of prior infection in the world, that they've not been able to achieve herd immunity even before this new variant. So I think this virus has turned our understanding of herd immunity on its head a bit.
Okay. Now, the government have announced a progressive relaxation of the lockdown measures, starting with children going back to school next Monday. And by the 21st of June, life should be back to normal. What's your opinion about the proposed timescale? Should we have confidence? Should it all be happening sooner? Should we get businesses back sooner? What do you think, Alan?
Oh, gosh, this is difficult. I mean, the latest figures, I think, are roughly about 6,000 new cases detected a day. 6,000 new cases a day, that's 40,000 a week. When this virus got established in Britain before we did anything seriously about it, people reckon there were about 30,000 cases. And on the basis that people are infectious for about a week. And now we've got about 4,000 new cases that we know about, add in those that we don't know about. So we are still much higher than that. So at the moment, as of what date is today, the 3rd of March,
3rd of March
2021, there are still too many cases in this country. And we need to get down to the few hundreds, not to the few thousands. The data is all going in the right direction. Having said that, the numbers are dropping. More importantly, the numbers of people in those groups who have been vaccinated are dropping. And remember that the big concern for the government, and I think the big concern for all of us, is we would get sick and arrive outside our local A&E department, and there would not be a bed to take us, and not be an intensive care unit bed to take us. And that was the driver, and probably still is the driver. And given the rollout of vaccination, I think it is reasonable to say, predicated on the continued success of the vaccine that I talked about at the beginning of this conversation, that by June, the combination of the projected reduction in cases plus the projected reduction in the severity of the cases, particularly in the elderly, would not be sufficient to take away the challenge of COVID, but would be sufficient to take away the challenge of COVID as a public health service emergency. And then to some extent, I think it's probably going to move from government to individuals' view about their own risk, because that's going to happen at some point in time.
So you're saying really that people after the 21st of June, people are probably going to have to use their own judgment and see how things go.
Yeah, I mean, I think if everything stays the same, and of course, as I say, they're unknown. We don't know whether they're going to be some horrible new variant. We don't know whether the vaccines are suddenly going to fail. I think both of those are unlikely. And actually, I think compared to some of the earlier pronouncements, it was all going to be over by Christmas kind of garbage. I think that if anything, the government have veered on the side of caution. And, you know, I'm not necessarily a supporter or an opponent of this current government, but I think given what I know and the timings, it probably represents the appropriate response at this time.
Right, I'm going to turn now, I'm going to read out the questions that have come in. Brian Shotlander sent about 35 minutes ago, sent me the following question. Is it correct that CAR T cells seem to be effective against a variant so far, but that antibodies from the vaccine are more variant specific, so that we may catch the virus, we shall stay out of hospital?
Yeah, so I mean, I mean, just without getting too technical, for most people, if this is the issue in the question, we have different ways of protecting ourselves against the virus, and most people will know about antibodies. The other bit of our immune system that gives us protection against the virus is something called our T cells. And T cells are very good because actually what T cells do is T cells boost antibody level, but T cells actually go out and kill the virus. And one of the things that's much harder to know is what the T cell response is going to be until it happens. We can measure our antibody levels, and we know that people have had a good antibody level response or a not so good antibody level response, and we can look at that antibody level response over time. We might not know about our T cell response until faced with the virus. And there's been a number of different studies that have come out recently, some from Cambridge, others from a place in the States and indeed from China, suggesting that the T cell response that is initiated or stimulated by the vaccines could provide protection, but we might not know that in the real world until it's happened or not happened.
Okay. Brian Conway sent in a question. Why are we seeing mutations of this virus which seem to be more virulent? Surely if the host, that's us humans, were killed off, the virus would not thrive.
Well, I mean, the answer to that is actually in the way that the question was posed. I mean, viruses exist. Their sole purpose in life is to multiply. That's all they do. They have a fairly boring life, but all they do is multiply. And viruses mutate the whole time. Interestingly, this coronavirus actually mutates less than other viruses. We were very surprised, really, that it took until almost the Kent variant at the end of last year for the virus to mutate anywhere like to a level that was important. So as you can imagine, what happens is that we have the virus, it's mutating, we create antibodies that actually get rid of different forms of the virus, and the few mutations that seem to be a bit stronger against the antibodies, they're going to have some preferential survival. So it's like in evolutionary terms, it's survival of the fittest. So as the virus mutates, the mutations are like the mutations that will grow, the mutations that will prosper are the ones that seem to have evaded the system. And actually, we've done very well. I mean, of course, there's another side to that, which there are some infections, and some people thought this was actually true for Mersenne, for example, is that when you have a viral mutation that causes severe disease and death, and actually you become sick very quickly, and you're much less likely to pass it on, in a way, the virus is not doing itself any favors because it's killing people before it can then be passed on. And the forms that survive are the less severe forms. I mean, despite what we know but what we read in the paper and all the horror stories about COVID, the overwhelming majority of people don't get it badly, particularly young people. So there's plenty of options for the virus to survive and be passed on.
Okay. Well, Jacqueline's asked quite a technical question here. Is it possible using viral genome sequencing to produce a vaccine derived from more conserved parts of the virus?
Okay, so let me explain that question, because it's a good question. Very early on, during the pandemic, the one good thing the Chinese did is they produced the complete genetic sequence of the virus, from, you know, Land's End to John O'Groats, if you will. Now, this genetic sequence would produce a very large protein. What the biologists understood fairly early on, that the key part of the virus, the part of the virus that was going to do the damage, was this spike protein that many people heard about. And this spike protein was the bit that attached itself to human cells. So if we can produce a defense against that spike protein, we didn't need to bother against the other bits of the virus. And all the vaccines that are, well, that's not entirely true, but all the vaccines that have been licensed are active against the spike protein. Now, some of the mutations, the Brazil mutation, South African mutation, etc., have produced mutations in the spike protein bit, and antibodies against that are not as successful. So one of the argument goes, well, why don't we try and produce a vaccine against a larger bit of the virus, rather than the spike protein? And was it, did you say Jackie asked the question?
Yes.
So when Jackie talks about the conserved sequence, what she means is there's a bit of the virus that doesn't change between people. It's exactly the same. It's conserved over time. So the suggestion is, let's produce a vaccine that works against a much larger bit. So if there's mutations in the spike protein bit, we can knock out the rest of the vaccine. And indeed, that's exactly what vaccine manufacturers are working on at the moment.
Okay. Tony and Eve have asked, should those who work in medical or social care organisations be required to have a vaccine?
Well, I think this is a good question. I mean, I think that there's two issues. I think there is what is needed to protect them, and what is needed for them to protect the people that they're looking after. And of course, the issues with care homes, the reason why the pandemic was such a disaster in care homes was because it was passed on by staff, particularly staff who were moving from one home to another. Actually, to be honest, Eve, there is a precedent for this. You know, I apologize, I don't know whether it's still the case, but I know when I was a junior doctor, I had to be vaccinated against hepatitis B because of the risk that I could pass that on to patients. So there is an absolute precedent for people being vaccinated. I suppose the only argument against it was if there is, and actually, to be truthful, it's very difficult to imagine who that very small group is. But if there's a very, very small group of people who cannot be protected, who can't have the vaccine for whatever reason, is there a human rights issue that they can't then follow their employment? But for the vast majority of health and care workers, from my own perspective and based on the precedent of hepatitis B, I would support that.
Okay. Andrew Powell is asking, what are we learning about long COVID?
Well, one of the problems with long COVID is that it's a blunderbuss term that covers pretty well the continuation of some forms of a variety of forms of ill health over a protracted period of time. Now, we do know that even things like flu, glandular fever, infectious mononucleosis, there's a whole number of viral illnesses where people have some protracted symptoms, particularly tiredness and fatigue. However, and that is clearly what is happening to a large number of people. However, there are some other specific syndromes that people are continuing to have. Some people have continuing upper respiratory problems, people have continuing lower respiratory problems, people have rashes, etc., etc. So very different individual syndromes. At the moment, there is no clear reason why some people get these and not others. The research is at the stage where these syndromes are trying to be identified and quantified and see whether there are distinct clusters. But the key question is, are we able to predict either from biomarkers, blood tests, is it related to the antibody response or other response? Is it related to our own genetic background? The answer is thus far, we don't know.
Okay. Bernard Ecker has asked, are details known of the breakdown of the categories of the current of those who have COVID age? Do you understand that?
No, I'm not sure I understand the question.
Okay. Bernard, I'm going to allow you to unmute yourself so that you can actually ask Alan directly.
Yes. Figures are published every week or every day, and you said about 40,000 people have contracted COVID. Do we know a breakdown of age, ethnic categories, or is it something that the government are not publishing for a particular reason?
No, the data are known, and you can go on the Office of National Statistics website. If you click on ONS pilot study, you can see that data, and it's published every week, and there's charts and figures and spreadsheets. So it is all there exactly as you said, by age, by gender, by ethnicity. I must confess I haven't looked at it for a few weeks, but up to the last time I looked at it, there was remarkably little variation in age, other than what you would expect based on the social distancing and other measures. I mean, at the moment, the highest proportion of cases are in younger people, and certainly, you know, when schools were in place, when people at university, etc., the age, young age, was the highest group. In periods of time before that, it was fairly constant. I think, in general terms, and because it is quite difficult because of all the challenges of equality of exposure. In general terms, it doesn't seem to be there are major differences between men and women, possibly slightly higher rates in men. In general terms, if you can allow for differences in how much contacts people have, the infectivity in children is the same as in adults. And the thing about ethnicity, in terms, I'm not talking about severity of disease, but in terms of the numbers of people who have contact, and that reflects what happened with the Haredi community. I think, yes, it does appear that there are higher rates, but it's probably explained by age and by household size, density of housing, etc., etc. And we also know, sorry, that prior to vaccination, there were higher rates in people in the health and care industries, occupations, referring back to a previous question.
Thank you much.
Well, Johnny Hill has asked a question here. We're coming towards the end now, folks. 60 to 70 million people will have to be vaccinated in the UK. That's 120 to 140 million doses. We manage 0.25 to 0.5 million per day, and it means a massive rollout of vaccination until Christmas, where we'll have to start all over again with refreshers or possibly new strains. Does that mean that some restrictions will be in place until the end of until next year at least?
I think, as I said at the beginning, I think maybe there's a lot the government have done wrong. I think the vaccination rollout program has been phenomenally successful in this country. And maybe apart from Israel, the vaccine rollout program in Britain has been astonishingly successful. And I think, as I said earlier, Johnny, that actually one dose of the vaccine is providing a level of protection which is, you know, welcome and not, and that wasn't necessarily anticipated. I think we accept that actually, and there are clinical trials being done in children at the moment, and obviously children and young, the vaccines aren't licensed for people under 18. I think with some vaccines it's under 16. But so there will be that large group that we'll need to think about, and probably that relates to school entry next year. I think what we have shown is actually, if you can organize yourself, we are perfectly capable of vaccinating very, very large numbers in very, very short time periods. I mean, it's a logistical challenge that we've never faced before, but, you know, if with accommodation, with resources, with staff, etc., this can be achieved. So I don't see that the rollout program is going to be a constraint. To be honest, I actually think we have done much better than anybody could have been predicted. You know, some of you know that I've been blogging about COVID, and in fact, it's just about over a year I did my first circular. And I remember I wrote at the time about a vaccine, and I knew that China had released a genetic code. And I wrote at the time, and I don't think, I mean, I was only quoting other people, I said, I would be surprised if this vaccine is sufficiently advanced and done all its toxicity testing to be in clinical trials by the end of the year. Boy, was I wrong. We had a vaccine ready to go into people well within 12 months. This was astonishing. This, I don't, you know, without going into details, that speed of development is faster than any other medicine or vaccine has been in history. And it is a phenomenal success. And there's a large number of reasons for that. I think it's in investment by the government. I think it's an investment in science. I think it is the regulators who said, look, we don't need years and years of testing, etc., etc. There was, to some extent, were there shortcuts taken? Yes, there were shortcuts, but I think those shortcuts that were taken were appropriate and managed risk. And also, I think, you know, what the British government did, which other governments didn't, when they knew companies were producing vaccines, they went out into the market and said, look, we're going to buy, you know, you haven't even started your clinical trial, but we are going to pay for this vaccine to be produced now. You know how to produce it, and we will have to wait 3, 4, 5 months before we know if it's successful. But we are going to spend money now investing in the production, and we will we will give you that certainty. And I think that degree of commitment and confidence by the people responsible for the vaccine rollout program is something, I'm not making a political point here, I think I'm making a kind of independent point, I think was staggering, and I think has proved to be successful.
Okay. Well, before I turn to Avril for the vote of thanks, I'm going to let Johnny Hill, I'm going to read out, I'm giving him a second go because what he's asked is actually very appropriate for closing. Without forgetting the enormous cost to people, societies and economies, are you glad as a scientist to be observing this phenomena?
Well, it's been a journey for me, and it's been a journey for a number of my colleagues. I mean, what I will say, it has transformed the pace of science. Just to give you an idea, if I today think I have an idea for a clinical trial, a new drug, or a drug that has not been tried in a disease before, and I wanted to test that drug in patients with a disease like COVID to see whether it was effective, it would have taken a year minimum to get the funding. By the time I had gone through the process of the consultations, filling out the application forms, going through the process, the application being reviewed, doing the contract negotiations, it would have taken a year. Once I had got the funding, it would have taken, on average, about, believe it or not, 15 months before the first patient was treated. So 2 years and 3 months from having the idea would be the first patient to be treated. For a trial that took 6 months to recruit patients and 6 months follow-up, that would take another 2 years. Then I've got to analyze the data. Then I've got to get those data published. 5 years from start to finish would be not unusual. We have seen that process gone from 5 years to about 6 or 7 months. And in a way, that has been the most breathtaking, exhilarating, if you like, part of science. I think, word of caution, we may find over time that some of the results that have been widely publicized in the media on a whole range of things related to the pandemic will prove to have not been sustained with more detailed, closer scrutiny to the quality of the research. But I think what the next generation of scientists have seen is that our pedestrian approach to doing science in times of public health emergencies was flawed, and the scientific community worldwide has come together and accelerated that pace of growth in scientific knowledge at a rate that many of us would have hoped could have been achieved much earlier.
Thank you, Alan. I'd now like to ask Avril Schindler to propose the vote of thanks on behalf of us all. Avril.
Well, Alan, that was a most amazing evening. Thank you very much, first of all, for giving up your time. You're a very busy man, we know that. And for answering all our questions so concisely, so clearly, and without a graph, without a next slide please, which was lovely for all of us. I think what I've come out of this with is that there are lots of reasons to be hopeful, although we will be in what I call the new normal. I don't think things will ever be quite the same again. The other point that came out for me particularly was your answer to the Haredi question, because people have been victimizing them, and I think now I have a different view of that. So really, just to say thank you so much. I would love to hear you again. I'm sure we would all love to hear you again, maybe after June when things have settled. Unfortunately, we're all going to be the second Pesach on Zoom, but what can we do? And just to say a huge thank you, and inspiring really, your last answer, you know, what humankind can do when the chips are down, and how we can all get together as a world to fight the plague, this awful plague. So thank you very much again.
My pleasure.
If you'd
thank
like
you.
to unmute yourself, and we'll give Alan our usual appreciation. Thank you. Thank you very much indeed.
Very
Alan.
Hear it from a scientist like that.
Don't worry, mister.
Thank you very much, Alan.
Thank you for joining us, everybody. Thank you, Alan.
Good to see you, Alan.
Thank you.
Thank you.
Very good.
Thank you. Keep up good work, Alan.
Okay. Thank you.